Good morning, everyone. Welcome back. I'm so happy to meet you again in this very important project about the role of point-of-care ultrasound in clinic in acute abdomen. Recently, I've seen a 30-year-old male patient who complained of severe gastric pain, hypochondrial pain after fatty meal, radiate to back. He is fully conscious and hemodynamically stable. Heart, he has dilated compensated cardiomyopathy, chest clear, abdomen soft, no signs of peritonitis. Really, in this type of biliary pain, ultrasound is very important investigation, and it is the imaging of choice in this situation. You will put the curvilinear probe in the 8 intercostal space, anterior axillary line, and in some patients you can put between anterior and mid axillary line. You will put parallel to the space, and you can tilt anteriorly and posteriorly to explore all the area. You will see here at the anterior border of the liver, here is the posterior, and there is the diaphragm, and you will see the gallbladder with hyperechoic wall and anechoic bile insides. In our patient, we saw very prominent gallbladder stones with shadow behind, and once you see this gallbladder stone, it is a biliary colic, but you need to explore two very important things. First, is there any gallbladder inflammation? Is there any element of acute or evidence of acute cholecystitis? This is number one. Number two, is there any dilatation of the common bile duct? It's very important complication you need to search for with the biliary colic. As regards acute cholecystitis, you will measure the gallbladder wall. The diameter is expected to be less than 3 milli. In our patient, it's 1.8 milli. And you will explore the porta hepatis here behind the gallbladder. Posterior to the gallbladder, at the center, at the umbilicus of the liver here, in the lower posterior half of the liver, you will explore this area of porta hepatis. This is very important to explore. Porta hepatis, very important area. This clip, you will see here the gallbladder, and behind the gallbladder here, posterior to the gallbladder, there is a porta hepatis with very important structures you need to explore in the porta hepatis here. You will expect to see 3 tracts and vessels, the portal vein going towards the liver, and the hepatic artery going towards the liver, and the common bile duct going away from the liver. These anechoic tracts behind the gallbladder is very important to explore. How can to differentiate between these important 3 tracts or structures? You need to fire the color. Any tracts will get the color. It is portal vein or hepatic artery. Any anechoic tract without color, it is the common bile duct, and this tract you need to measure in case of biliary colic to be sure there is no acute dilatation of the common bile duct by impacted stool. This is the porta hepatis. Any tract getting the color, it is the portal vein or hepatic artery. Any anechoic tracts in the porta hepatis behind the gallbladder at the umbilicus of the liver, it will be common bile duct, and you need to measure. This is the porta hepatis here behind the gallbladder. There is 3 tracts here going present in the porta hepatis. The anechoic tract here, not taking any color, probably is the common bile duct, and there is 2 tracts here, 2 vessels here getting the color. Both the vessels flow is going towards the liver because it is the red color towards the liver. How can I differentiate between the portal vein and the hepatic artery? Number one, portal vein is a continuous flow because it is a venous flow, but the hepatic artery is the pulsatile flow. And if you fire the spectral Doppler in this area, you can very easy to differentiate between the portal vein with continuous flow, hepatic artery with the pulsatile flow, and the portal tract with no flow. The continuous flow of the portal vein, when I shift the spectral Doppler here, I will get the pulsatile flow of the hepatic artery, pulsatile flow of the hepatic artery continuous flow of the portal vein, no flow of the portal tract. And here the flow is going with the portal vein. This is the anechoic flow is the portal tract. Back to our patient. This is the first ultrasound. Our patient has no evidence of acute cholecystitis, and at the same time normal diameter of the common bile duct 3.7. That means good news, no common bile duct dilatation. Patient improved with IM diclofenac and was giving orthofalc, used oxycholic acid, asked to do hemoglobin electrophoresis because really of two things. Our patient is not obese and has very significant history of gallbladder stones and has dilated cardiomyopathy, and in this situation we need to exclude any hemoglobinopathy, sickle cell disease or thalassemia, because both can cause recurrent gallbladder stones and hemochromatosis can cause dilated cardiomyopathy. And we advise our patient to do cholecystectomy because of recurrent attacks. Few days later, patient presented with persistent pain, partially relieved with analgesic, no fever, dark urine. Second ultrasound. This is the importance of point of care ultrasound in the follow-up of your patient, because if any complication happens, you can get it at the proper time and you can deal with. This stone is still there. Gallbladder seem to be well, no evidence of cholecystitis, no distended gallbladder wall and no pericholecystic halo, and a lot of tracts here in the porta hepatis, and I need to explore this tract. And as I said before, you need to fire the color to know what is the portal vein, what's the hepatic artery, and what's the common bile duct to measure to diagnose dilated common bile duct. Stones, small stones, because this small stone is very easy to slip in the common bile duct and cause acute dilatation. Our patient has no gallbladder wall distension, normal diameter of gallbladder wall 2 milli, and I fire the color. Common bile duct seem to be dilated. I fire the color here. In our patient, there is 3 tracts in the porta hepatis here. The common bile duct anechoic with no color flow at all, hepatic artery pulsatile flow, portal vein continuous flow, and there is very important points here in our patient. This intrahepatic tram tracts. I find here 2 tracts going with the right branch of the portal vein, flowing together, both taking the color. This is the branch of the hepatic artery, and this is a branch of the portal vein, but this last tracts is not taking the color and the anechoic, and this is the branch, the common hepatic artery, common bile duct going to common bile duct. So this is the tram tracts inside the liver. This is the tram tracts inside the liver. This is the evidence of intrahepatic biliary dilatation. So our patient has persistent biliary pain, not relieved completely by analgesics, and by excluding the porta hepatis, there is dilated common bile duct with intrahepatic biliary dilatation and dark urine. I need to measure this common bile duct. In this ultrasound, it's 8.1 millimeter. I know the previous one was 3.7. That means there is acute dilatation of the common bile duct with persistent pain, denoting a stone impacted in the common bile duct. This is very important possibility. This is really a common complication and famous complication of multiple small gallbladder stones. All liver enzymes were shooting up. Total bilirubin and direct bilirubin was high. Patient was sent for ERCP and common bile duct stenting. Third ultrasound, good news, after successful stenting, and you see here the hyperechoic stent inside the common bile duct, and common bile duct here became 4.8. The diameter decreased, denoting Very good improvement, good news. The common bile duct will drain by stent, and the bilirubin decrease, and the alkaline phosphatase and the GGT decrease, and really, as you see here, even intrahepatic biliary dilatation, no tram tracts. This is the first ultrasound with tram tracts, second ultrasound, no tram tracts, intrahepatic biliary dilatation, improved, common bile duct drained and decrease in diameter. Good, well done, all are happy, I am happy, patient is happy, and gastroenterology, the interventional gastroenterologist is happy, all are happy, good news. 1 week after patient presented with severe persistent pain, high fever rigors. Another scenario. We get the fourth ultrasound for our patient. In this time, the image differ than previous times. We saw in these times very strong evidence of inflammation in our patient, which is not present in the previous sonars. First, you see the common bile duct wall is distended 6.3 millimeter more than 3. That means there is evidence of cholecystitis and inflamed gallbladder, and there is pericholecystic halo denoting edema. And when I fire the color, as you see, we found very vascular and inflamed gallbladder wall, and very vascular area, inflamed area, very apparent. You see hyperechoic mesentery denoting acute inflammations, inflamed area. Moreover, I find lymph nodes appear very clear in the porta hepatis, denoting inflammation, the infection. You see distended gallbladder wall, vascular, inflamed area with prominent fat strand, hyperechoic mesentery, all these going with inflammation. You see lymph nodes. Moreover, really here you see, this is the first ultrasound. The gallbladder wall was seen, and you see here the liver inside. I didn't see any prominent portal tracts, but during inflammation in the fourth ultrasound, I saw a lot of portal tract prominent here, denoting inflamed portal tract, most probably cholangitis. This inflamed portal tract not apparent previously here. So, in this fourth ultrasound, we find all evidence of acute inflammations and infection in our patient, but fortunately, patient responded to this time to antibiotic, and they arranged for cholecystectomy and the removal of the stent. So, as you see, point of care ultrasound go with you step by step in all the stages of management of our patient, starting from the diagnosis of the gallbladder stone and biliary colic, and going to the first complication, which is acute dilatation of the common bile duct by stone inside the common bile duct, and we follow up the stenting and successful stenting and the clearance of the common bile duct and the intrahepatic biliary dilatation, and lastly we diagnose infection and the florid inflammation very clearly by ultrasound, and in each step we take a different management. At the beginning we give only analgesic, after that we did stenting to the common bile duct, and at the end we did aggressive antibiotic and arrange for cholecystectomy. And this is the power of point of care ultrasound with your hand, with management in your patient in the clinic. Thank you a lot for appreciated listening. See you in another point of care ultrasound in clinic.